And now we'll go to another case of a male patient, 47 years old. He complains of weight loss without anemia, about 12 kilograms in about 3 months. MRI abdomen and pelvis in November 2019 shows small focal lesion in the head of pancreas, about 2 centimeters in diameter. CA 19.9 is 48. The patient is for EUS evaluation.
It's very bad.
Hello, good morning.
Hello.
Hello, good morning.
Good morning.
Hello.
Good morning. So first, thank you for the invitation, for the kind invitation. I'm here with a great team in this great facility. Dr. Mohammed from anesthesia, Hanet is helping us. Thank you so much. And I'm supervised by top one in US in the world, Professor Giovannini.
You are too kind. You are too
Real
kind.
honor. So I'm sure that won't be, I won't do anything wrong here because my master won't let me, okay? So you know this patient history, and even though we think that the patient has a mass in the head of the pancreas, usually I begin through the stomach and I see the body and the tail of the pancreas, look for lymph nodes. I think that's just one way to do the examination. So usually I see the aorta and the celiac trunk, as you may see here, and Mark is being so kind to point for you. If I give a right rotation, see the adrenal gland. And if I do a counterclockwise rotation, usually I see the porta hepatis, as you see, the portal vein. If I go ahead with the portal vein here, I'm gonna reach the splenomesenteric junction and the pancreas. So here the splenic-mesenteric junction and the pancreas is just above us. So you see the body of the pancreas, and the first thing that we should know, should look for is pancreatic dilation. You see the SMA, superior mesenteric artery, just below it. And I think Mark agrees with me, there is no dilation in the PD.
No.
So it's important because if you have a mass in the head of the pancreas, is adenocarcinoma the first diagnosis, and adenocarcinoma begins at the duct. So it causes ductal dilation. So with a clockwise rotation, I'm gonna go to the tail of the pancreas, as you may see here, and the splenic vessels begins to appear. So it's a little bit hypoechoic, this gland, right? But it's homogeneous. I don't see any mass or any problem. What do you think, Mark?
Could be autoimmune pancreatitis.
Yes.
This is a young patient with no visible main pancreatic duct because it's very, very thin, and with a mass in the head and this hypoechoic pancreas. Could be.
Yes. Okay, that's very important when we're gonna choose the needle they're gonna use for this patient, right? When we see in this situation. Once again, the SMA here, superior mesenteric artery, okay, and just below it, we see the celiac trunk, and once again, the porta hepatis. And if you had a dilated CBD, would be just behind the portal vein, but you don't see it, right?
No.
There is no dilation behind the portal vein.
It's an inflammatory node, so
Yes,
probably.
inflammatory lymph node, yes, for sure, yes. So, I think are you happy with this study?
Perfect.
So, okay.
Very good.
Great.
Now
So,
you pass into the pylorus now.
perfect. I go into pylorus. And
And-
this is the head of the pancreas and the portal vein. And the confluence just here, as you see, splenic vein and superior mesenteric vein. Okay? And the head of the pancreas is just here. So let's look for the mass. Maybe here, right?
Yeah, it's
It's a
there.
little bit different.
Yeah. It's
So-
more hypoechoic.
More quick, yes.
Yeah.
So you can appreciate the lesion here. Yes, I think it's time for measurement. This is freeze. I think freeze is here. This one.
Freeze.
Yeah, freeze.
Okay.
Yes.
Don't push.
Yes.
Doctor, according to the
So you-
picture
you-
of pancreas, is it any possibility of chronic pancreatitis?
The question is if
If
this
there
is
is some sign of chronic pancreatitis.
actually is. I
Hypercoat,
wouldn't
foci.
expect. I wouldn't expect this finding. Or see this heterogeneous hyperechoic strands here, but I don't see unequivocal signs of chronic pancreatitis, right? So, but still, this is not normal. This is abnormal, and this. Sure.
We will need more examination for some some time to preparing another one.
Okay,
Okay.
thank you. So, anyway, we're talking that this irregular shape, the irregular border, these hyperechogenous strands here, they
Yes.
could be chronic pancreatitis, but are not unequivocal signs of chronic pancreatitis. As you know, if we see just a few signs, we can rule out chronic pancreatitis. If you see a lot of signs, we can tell for sure this is chronic pancreatitis. The problem is in the middle, is in the gray area. You have just a few signs, just as this one, hyperechoic strand, lobularity, but then this could be anything, right? You can tell this is chronic pancreatitis.
No, I
But-
think.
yes, please.
I think no. This could be also a compression of the pancreatic tissue by the nodule here, and I saw this, and probably the diagnostic of autoimmune pancreatitis is because the aspect is not an aspect of adenocarcinoma, not an aspect of neuroendocrine tumor, because it's irregular. And
Contrast would be useful in this situation,
yes,
Mark, what do you
contrast will
think?
be very useful, and also the elastography, but we don't have le Doppler, il le voit pas là-bas.
Oui. Oh, I put some Doppler because I was curious to know what is this structure here. To cut the Doppler? Okay. To know what is the structure here. Is this a duct, dilated duct, or is a vessel? Because if it is a dilated duct, that I would be worried, right? I don't.
I think that's. I will see like this.
So this is posted Doppler?
Yes,
Yes.
but I don't know.
I think the same. Once again,
The same, no,
one.
the same, no. It's
No, the same doesn't work.
I don't know. I don't know where is the.
No, yes,
yes.
you got it. You got it. Maybe it's a vessel, right?
Yeah,
I
it's
see
a,
some-
it's a vessel.
It's a vessel.
It's a vessel. Yes. It's a
You can
vessel.
appreciate there is some pulse.
Yeah.
Okay, you cannot hear, but you see the image. So, very clever. So this is not a duct, this is a vessel. This is very important because if this is a duct, it's a dilated one. And a dilated duct interrupted in a mass, this is very worrisome, right? This is very compatible with malignancy. But that's not the case. So, using pulsed Doppler,
Yeah.
Dr. Giovannini showed us that this is probably a vessel and not a duct. So again, this lesion doesn't seem to be adenocarcinoma, doesn't seem to be neuroendocrine tumor, so autoimmune pancreatitis would be a fair diagnosis for this patient. And
yeah.
now it comes a very important thing. So if we think it's autoimmune pancreatitis, the selection of the needle is very important
Yeah.
because we know from the literature that FNA is not
Not
good,
enough.
not good for this diagnosis. Do you agree?
Fully agree. Fully
Fully
you
agree.
need histology. You need
We need histology.
the architecture of the lesion.
So this is very important. So there is a study from Japan using FNA and showing that you could make a definitive diagnosis in only 20% of the cases, very low. But the same group did a multi-center study in Japan, and using FNB, they could reach a good diagnosis in 70%, much better. So that's why you're gonna choose a core needle biopsy.
Okay.
And here we have
The
acquired.
acquired needle. yeah.
Acquired needle, yes, acquired needle is Francine, it's called Francine
Francine
needle.
needle, yeah.
Francine needle, because of the design of the tip of the needle.
Because
okay?
this is a Francine needle is a very old needle. The design was done in the year 80 for the diagnostic of breast cancer.
I didn't know that.
Yeah, it's
Great.
the design of this was after abandoned for many reasons for the cutting needle,
I see.
and they come back now with the EUS.
You see? You
and
see?
then
Very good.
this is an
Professor
old
Giovannini,
story for this needle.
Is there a
Professor
question?
Giovannini, as regards autoimmune pancreatitis with extensive fibrosis in type 1 with storiform fibrosis, we may expect also to have some sort of dilatation of the pancreatic duct. So the mere dilatation of the pancreatic duct does not indicate malignancy
No, in
only,
this-
but it
in
could
this-
be also with autoimmune pancreatitis.
One of the signs of autoimmune pancreatitis when there is a mass is that the pancreatic duct is not dilated. There is some case of publication of a pseudo-tumoral mass with a double dilatation, but this is very rare. And mainly one of the main sign is so-called ductitis, is the inflammation of the wall of the main pancreatic duct, and the duct is quite not visible on the EUS, and it's very, very thin on the MRCP.
Okay. Thank you, Mark. And now I use this acquired needle.
Yeah.
I remove the stylet to make the needle more flexible. I don't know if you agree with that, if you use this. Yes. And then you can see here
I'm sorry.
the tip. No, they can see here the tip of the needle. And I can advance quickly and try to find the tip of it. Oh, okay. Let me try to do a better job. It's not good the way
Maybe
it is.
if you want,
Yes,
I can help you to maintain the scope.
Here is good position.
Yeah.
It's difficult to see the tip of the
It's
needle.
very important to see the tip. I think you are very
yes.
deep. Huh?
Yeah,
No?
I think so. Yeah, let me move.
Yeah,
yes,
yeah,
here.
yeah,
Yes, now you
yeah,
can
you
see
are.
it.
Now
yes.
you are.
Okay.
You are.
Okay.
You
So
are
I think
inside.
in a good position.
Yeah.
Okay, in a good position. So I use suction.
Okay.
Do you use suction, Mark?
Yes. I use suction. Sometimes when the lesion is an hypervascularized lesion, like neuroendocrine or some metastasis from renal cancer, the first pass I don't use suction. I use a slow pull or no suction, and if the specimen is not adequate, I will do a second pass with suction. But for pancreatic cancer, I use always suction.
Yes, me too. That's my experience. I use suction. I don't like other techniques like wet suction
but in the literature and the recommendation of the ESGE is only the recommended technique is to apply 10 milliliters vacuum, and all the other technique like wet, with stylet, no stylet, all the techniques, there are the similar result.
Yes.
The only technique, it's the fanning technique, which is to change the way of the needle during the punction.
I tried to do it, but I found some difficulty to do it.
And sometimes it's not possible. This was proved by a very small randomized study published by Shyam Varadajulu in Orlando. But there is now a second study published also, but with very few number of patients. They show that it's better than to perform the biopsy always, and the back and forth movement always in the same area.
Oh, interesting. So we did like 15 to 16 oscillations with the needle under suction, and 10 cc of suction. And now let's see what we've got. I think as we obtain core, we should put some of the material on formaldehyde, not only slides. Okay?
You have a nice specimen.
So in formaldehyde.
You have a core. You have a core.
Stop to put in the slide, and
you
now
have a black,
the bottle.
You have a white core. You have a white core here, which is important to show.
And I would say that it's very important to talk to the pathologist while you're doing this procedure. So you ask him or her how he wants you to conditionate the material. So you take the specimen, and what does he or she want you to do with the specimen? So part in the slide, part of the specimen in the bottle. So with my pathologist, I put everything in a bottle of formaldehyde, and the pathologist processes like a cell block. Okay, but here you are putting.
I don't know if you see.
Can we see the specimen?
Okay.
If you can focus. If you can focus on this, I should. Here you have a very white tissue. You see? I'm sorry, there is a lot of blood.
A big specimen.
But here you. Yes,
this.
Okay, here, if you can focus.
But that's nice. That's nice.
You see, this is pancreatic tissue. because it's completely white. It's not clot. It's not clot. This is clot, but this is pancreatic tissue.
So
and
maybe we should put
this in a formaldehyde.
formaldehyde.
Yeah.
Yes, this is very important. So this is kind.
But
Yes,
this
we
is-
could
this is
have
white.
rows
This is the
that's
tissue.
rapid
You should put
on-site
this on the-
pathology again, and we can also have MOS, that
You see
macroscopic
here you have,
on-site evaluation. And macroscopic on-site evaluation is usually done with a magnifying
No,
lens,
there
but
is a
you
white,
can use,
tissue
you can
on
also do
inside.
as Dr.
Yeah, you
Giovannini
see the white
did.
tissue?
So he looked and saw the specimen, the white tissue, and said, no, this is good to put in formaldehyde. So this is kind of MOS.
Yeah,
So
this
and we
is
are
this is a
second
very well
pass
done
here.
biopsy and a very well demonstrated case. So we will have to leave you for now, and we will shift to another case.
Okay, thank you very much.
Thank you very much.
This